Welcome to the Northwest Ohio EMS BLS Guidelines. I am Dr. Daniel Schrain. Today we're going to be talking about the EMS BLS Guidelines in regards to the purpose of these guidelines is to provide both the EMT and the hospitals with a set of guidelines for management, treatment, and transport of patients with a variety of illnesses and injuries. Again, these guidelines are designed with the intent to provide guidance for management of almost all patient type. Knowing that every EMS encounter can potentially be different, these are not a set of protocols where you must follow X, Y, and Z. Yes, the intent is that all EMS providers should follow the guidelines, but also use the knowledge that they have gained both from EMT class or EMR class, along with any continuing education. These guidelines are set up into 9 different tabs, with tab 1 being the operational, tab 2 being the cardiac, tab 3 being the adult medical, tab 4 is the obstetrical, gynecologic, and neonatal resuscitation, tab 5 is the pediatrics, tab 6 is the environmental, tab 7 is trauma, tab 8 is all the procedures that are allowed, along with tab 9 being the medications. Again, the intention of these guidelines is a one-stop shop for all providers to be able to use as a resource when caring for patients within the Northwest Ohio EMS Consortium. On to tab 1, operational guidelines. Tab 1, Guideline 1, Clinical Practice Standards for EMS. The Northwest Ohio EMS Consortium is currently made up of 4 physicians, myself, Dr. Newmeyer, Dr. Ed Wojnowski, and Dr. Matthew White. The consortium website can be found at www.nwoems.com. The initial portion of Guideline 1 in tab 1 is just looking at definitions. What specifically is an incident, what is a patient, and then in the policy side of it, we all agree that EMS providers should work within the state of Ohio scope of practice for their level of certification. Also, EMRs, EMTs, advanced EMTs, as well as paramedics shall maintain a BLS certificate level through either the American Heart Association or the American Red Cross. Likewise, paramedics should also maintain an ACLS and PALS certificate. The ITLS certificate, though recommended, is not a requirement. Continuing the policy, the rest of it's looking at assessment, treatment, and then ultimately documentation. Everything should be documented. Any patient encounter, contact, as long as it's not a third-party caller. If you make patient contact and take vital signs, you should at least have some form of documentation. Standard of care for all patient providers should include scene safety primary survey along with vital signs and GCS. Chief complaints histories as well as the secondary surveys. And then developing your treatment plan and ultimately patient transport. Just remember that not all patient transports require a Code 3 or in some institutions what's called a Code 27 lights and siren transport to the hospital. Always remember Ohio is a due regard state. Guideline 2 is the EMS scope of practice that all providers should review. Tab 1, Guideline 3 is documentation of vital signs. The intent of all EMS providers, the initial set of vital signs should be complete in nature, including a pulse, systolic and diastolic blood pressures, if able to obtain, respiratory rate, along with a GCS, and then, if applicable, pain and severity scores. The pulse, respiratory rate, and systolic and diastolic blood pressures, or the big 3, shall be a manual blood pressure, manual pulse rate, and manual respiratory rate. And then again, all these should be documented appropriately. Likewise, additional measurements including pulse ox temperature and end-tidal CO2 are available. Patients refusing evaluation, always make sure that we assess those patients based on their mental capacity, which we'll talk about in a bit. ALS utilization, there are a number of different criteria of why EMS providers, including the EMT and EMR, as well as some advanced EMTs, should contact a paramedic backup, including abnormal vital signs, abdominal pain, chest pain, neurologic issues. And then on the trauma side, also things with the anatomy type problems, physiologic type problems, burns, and then the geriatric and mechanism of injuries. Care for all patients cannot be transferred to a lower level credentials, i.e. a paramedic should not transfer care to an advanced EMT if that patient requires a paramedic skill set. Patient disposition is set up into three different things, either the emergent, immediate life threat, the emergent, no immediate, or the non-emergence. The emergence would include things like unstable airways, STEMI strokes, and trauma patients, and they should be able to, or those patients shall go to the most appropriate facility that can handle that type of emergency. Emergent non-life threat, the patient should have some request, or they should be determined from the aspect of where they should transport, and on-scene time should be no more than 20 minutes. Non-emergence, of course, we shall, if appropriate, maintain and honor the patient's request of where they would like to go. Other technical locations include combative patients, ingestions, and then, of course, the pediatric patient. Under Section 5 of this, the no patient contact, no incident found, or third-party calls where the patient states they did not call for EMS assistance, again, we do not need to obtain written refusal or release at the scene, or even the aspect of obtaining vital signs or patient assessments. Tab 1 Guideline 6 is a laundry list of places for appropriate transport. Tab 7 is the activation of air ambulance or the Coast Guard. The ideal fashion is if you can transport a patient to the hospital within 30 minutes. The utility of activating an air ambulance is almost futile in most situations. Now, there are some times where you do have a patient that during that 30-minute transport would require additional services that you might not be able to render, and thereby waiting for an air ambulance might be appropriate. Specifically, things like prolonged extrications or airway problems that you cannot ventilate with a BVM. Likewise, for those individuals working on the islands or in the northern region where the Coast Guard is potentially needed, there's multiple steps that are required, including calling the control group in Detroit, and then ultimately the Coast Guard ship commander in Marblehead. Guideline 8 is the aspect of communication failure, or the whole aspect of all the different hospitals within the region are included here. Most institutions have some form of calling in via either med control radio or through the telephone system. I do have the air ambulance phone numbers for the northern region. The last part is the med control, the default fallback. If you're unable to get med control either through radio med channel or by a phone at another institution where you potentially will be transporting those patients, always remember that St. Vincent's is where the group that, for the most part, runs the Northwest Ohio EMS Consortium is based out of. So 419-251-4354 is the phone number that you should have programmed in your phone. When you do call this, of course, there'll be a administrative person that will be answering the phone. Just simply introduce who you are and tell them that you need to talk with an attending physician. Once the attending comes on, of course, introduce yourself again to them and explain what you need, the issues, and all that stuff. And then also make sure that you document on your PCR reports. Under Guideline 9, this is actually multiple different things with the medical legal. Just remember that for the most part we have to obtain some form of consent. Under the age of 18, there's an implied consent along with emergencies. Over 18, as long as the patient has mental capacity, which is a 3P standard, understanding that the person knows the nature of the illness, they understand the proposed treatment, and they have sufficient emotional control, both for judgment and discretion, to manage their own affairs. If they do have mental capacity, then anyone over the age of 18, we have to have at least verbal consent. Remember, as EMS providers, we do have a duty to act, and then also in the aspect of keeping the information confidential. Do not, I repeat, do not put anything on Facebook. Do not tweet anything. And remember that HIPAA laws do apply. There are times, though, that we have a potential learning experience on different cases. If that is the quote-unquote case, then make sure that you perform a peer review type training session. Ideally, all parties involved would go into a single room, close the door, and call it peer review, M&M, or whatever else. As long as you discuss it under peer review, that information is protected by Ohio law. Once you leave that room, know that anything further discussed can be discoverable in the court of law. Guideline 10 is pretty much the discussions on refusal of treatment and transport, who may refuse. Ideally, throughout the guidelines, the consortium physicians have several patient types. Your diabetics that feel better, your asthmatics that feel better, patients that have been tased and are going to jail, or simple injuries that don't require any additional type treatment. Those types of patients can be released at the scene. Otherwise, most other patients should be against medical advice type transport. Just remember that all patients must be considered alert, oriented, not under the influence of alcohol, drugs, or medical conditions that could impede his or her decision-making abilities. The remainder is just a discussion of who can be released at the scene, and then, of course, talking about the false calls of third parties again. Under Guideline 11, physician at the scene, the state of Ohio, any physician has the ability to be on-scene medical control. Now, there should be some stipulations. These type of physicians should be a general practitioner, i.e. family doctors, internal medicine, or a surgeon, or even better, a emergency physician. If they're a psychiatrist or a podiatrist, they should not be on-scene medical control. All physicians, there are some criteria that they need to adhere to. They should be able to provide proper identification. You need to contact online medical control and that they are assuming care. From there, they have to transport the patient to the hospital. Any verbal orders that are given to the EMS crews should be documented and that individual should sign. Just remember, though, that you cannot go beyond your scope of practice even with a physician on the scene. And the lastly is that they assume all medical care for the patient. If the patient has a poor outcome, There's a lot of insurance companies that do not cover these physicians in the pre-hospital arena. Guideline 12, Infectious Control. Pretty much the biggest thing here is remember, don't take the stuff home. Use your gloves, wear your goggles, if need be, put gowns on and all that stuff. Guideline 13, Practitioner Disciplinary. The first part is just the Ohio law that states where EMS providers require a medical director. And then this is the intention of what would happen if something got up to the medical director's level of discipline. Of course, there'd be a written explanation within 3 working days to address the problems. We would sit down and have discussions with the individuals, and then from there, if unable to work things out, we would go through a several-day wait period and then come back and have a further discussion. After all that was done, the medical directors, along with the individual chief, would come up with some form of disposition, being either no action, remediation and training, temporary suspensions, or even severe enough permanent suspension. The medical directors feel that any suspension in one jurisdiction is a suspension in all jurisdictions within the Northwest Ohio EMS Consortium. Guideline 14, this is where the remainder of the EMS guidelines start. On the right hand side you'll see the legend. So anything in white is an EMR status, anything green's an EMT, yellow's advanced EMT, red's a paramedic, and then blue is a med control order. On the left hand side you're looking at the scene safety, of course, followed by universal precautions, responsiveness, either your GCS or your AVPU. Initial assessments, if there's any unresponsiveness, of course, cardiac algorithms. Airway procedures that you can perform, vital signs, maintaining or checking glucose, and then treatment for low. And then considerations for anything with additional testing requiring monitors. Ultimately, go into the appropriate guidelines and then appropriate transport destinations. Tab 2, Cardiac Guidelines. In the chest pain, pretty much the initial treatment therapies, of course, going after the universal patient care is administration of aspirin. After that, as long as you are not delaying care and have the ability to transmit, EMTs are allowed the aspect of applying cardiac monitors. Often we can actually be able to transmit these EKGs to the receiving hospital, and if it is a true ST elevation myocardial infarction, they are able to get the proverbial ball rolling so that these patients can be either properly treated there or appropriately transported. After that, contact med control. Nitroglycerin, even though it is in the scope of practice as an EMT, it is still listed as a med control order. Unfortunately, this is one of those medications that have the potential of causing a lot of harm to patients, specifically without being able to assess an EKG. Ultimately, we do have the next guideline, which is congestive heart failure. Very often, EMS providers can do a lot of good with the ability of performing CPAP prior to transport and then during transport on a congestive heart failure patient. Of course, cardiac monitor and then appropriate cardiac care in transport. Cardiogenic shock, there's very little to do in for a patient that's hypotensive with having heart problems and all that stuff. The biggest is airway management, of course, obtaining EKGs, and then transporting these patients. Cardiac arrest, this includes both the adult and the pediatrics. We will discuss a little bit about the dead on arrivals. Otherwise, though, the most important thing in a cardiac arrest is a BLS provider, i.e. a firefighter, an EMR, an EMT, because it's all about chest compressions. The only things that have been truly proven benefit is high quality chest compressions along with early defibrillation. Of course, AEDs, and then ventilation of the patient, 8 to 10 breaths per minute. The ideal goal, though, is if you do not do any ventilations for the first 4 to 6 minutes, or even up to the first 10 minutes and just applying some oxygen on the patient, that is ideal. Otherwise, remember that an EMT in a patient that is pulseless and apneic can insert a blind insertion device, i.e. a King LT, a combi tube, an LMA. The resuscitation patterns at this moment in time is really looking at several different things. The first being the pit crew CPR that we have a lot of different training on. The other aspect is that wherever the resuscitation measures started, that's where they should be continued, i.e. where the patient fell. If the patient remains in sustained ventricular tachycardia or fibrillation greater than 20 minutes, then consider transporting those patients is appropriate. All efforts, of course, again, should follow the simple mnemonic MCMA, looking at the metronome, i.e. having a rate between 100 and 110 beats per minute, ideal chest compressions, and then monitor or AED along with airway management. Just to reiterate, CPR should not be terminated or stopped for anything. Do not attempt to intubate, or do not stop CPR to attempt to intubate. Do not stop CPR to attempt to put in an IV. Once chest compressions are started, they should not be stopped. Yes, you need to do your periodic pulse checks, but otherwise do not stop chest compressions for anything. The maternal rest, of course, we need to make sure that we take care of mother. If we're able to take care of the mother, then the fetus inside of her will be appropriately treated. In the pediatric sides, most arrests, of course, are secondary to hypoxia. This is just the simple aspect of algorithms for the American Heart Association. Guideline 5 is the pit crew CPR, where the first page describes all the different positions. So specifically on the pit crew, this is an ideal 4-person type thing, where each individual person has a responsibility, just like a pit crew in NASCAR. Position 1 is on the patient's right, checks pulse, and if no pulse, immediately starts chest compressions at a rate of 100 to 110 beats per minute. Position 2 is applying the AED pads along with every 2 minutes rotating with position 1 for chest compressions. Position 3 readies the King airway or other blind insertion devices, with position 4 taking notes, helping where appropriately, gathering additional information, and then also ensuring that adequate chest compressions and ventilations are occurring. Guideline 6 includes the hypothermic side. So any patient that, of course, is under cardiac arrest or in hypothermic, we should be treated for the hypothermia along with the chest compressions. Under the moderate hypothermia, of course, start chest compressions and then attempt defibrillations. Otherwise, if they're profound or severe hypothermic, one-time attempt at defibrillation, and then, of course, CPR. These are typically low-and-go situations, of course, waiting for the 20-minute time period to help out. but all patients, just remember, no one dies until they are warm and dead. In the traumatic arrest, these things, of course, has different venues in regards to what's going on. Obtain the spinal immobilization, and of course, if they do not have a pulse, initiation of cardiac algorithm is appropriate. If you're unable to obtain return of spontaneous circulation, you have to consider other things, including stabilization of long bones or pelvic fractures, or even from the aspect of external hemorrhage. Otherwise, contacting med control in transporting these patients. For cardiac traumatic arrest type patients, the closest appropriate emergency room is the ideal place. Minimum radio report should be given, which includes TAGM, trauma guidelines, age of the patient, gender, ETA, mechanisms of injury, and then vital signs where appropriate. Tab A is just the AHA guidelines, with Tab 9 being the dead on arrival guideline. So basically this is a multi-step to see if initiation of therapy should ensue. If there's incompatibility of life, signs of decomposition, the patient has been reliably been without any resuscitation measures for 20 minutes, there's an active DNR CC or CCA, along with if they have any of those things, then of course termination or actually initiation of cardiac resuscitation is not needed. Otherwise, termination, or if the patient does not meet termination resuscitation, then appropriate resuscitation should ensue. On the termination resuscitation, of course, is a multi-step process. If the patient does not meet the DOA guidelines, and for those with blunt traumatic arrest, the whole process should be geared towards trying to get an ALS provider there. Any patient that is an asystole deemed by ALS, all resuscitation measures can be terminated. Otherwise, the patient, if they've been reliably without any vital signs for 20 minutes, without any resuscitation measures, the patient must be non-hypothermic. AED does not advise the shock. If resuscitation measures have been initiated, then cardiac arrest guidelines should be followed for at least 20 minutes, including a appropriate airway. And the final is the aspect of a end-all catch-all for the potential of transporting the patients. So if the family does not have some emotional support, then of course it is best to transport those patients to the hospital. Of course, whenever in doubt, always assume the patient is a full code and initiate cardiac arrest. The DNRCC, these are guidelines set by Ohio law, basically stating what we will do in the event of a patient that has a DNR, both either a CC or CCA. And then the second part is the actual form. So with this, the check boxes should be made in regards to either CC or CC arrest. The patient's name and information should be filled out, at least their birth date. Signature, of course, is optional. From the other aspect, this has to be completed by a physician. Nurse practitioners, physician assistants, or anyone else cannot fill out this form. They should either have a DNR order or living will. And then, of course, the physician should sign their information, have their name, address, and all that. This should be, of course, done in blue or black ink. Unfortunately, I have seen these forms done in crayon, which are not appropriate. Guideline 12 is just the aspect of the LVADs. We are seeing a number of these in the area, including some of the different hospitals, UTMC, Columbus, along with Cleveland and all that stuff. Just knowing that the major cause for patients with LVAD, it's usually either due to battery or device malfunction, or a what's called a hypercoagulable state, where the motor itself becomes clotted and blood is unable to flow. Therefore, CPR should be a last-ditch effort if there is a defective device and the patient is unresponsive. Tab 3 is the initiation of the adult medical, with the first one being the abdominal pain. Of course, universal patient care, make the patient NPO. If they have signs of dehydration, some of the departments are carrying wrist guards, which is an appropriate device. Otherwise, anyone over the age of 40 should have an EKG, and then appropriate transport. Alcohol intoxication, this guidelines was initially... With this guideline, of course, we'll be looking at the universal patient care along with the aspect of clinical alcohol intoxication. Of course, this is a very hard and nebulous thing to determine who is clinically intoxicated. Any concerns, of course, always take immobilization, consider airway management, and then blood glucose therapy. The next piece is trying to determine do the patient need to be transported to the hospital or can they be released? Any signs of incapacity intoxication, which means the inability to maintain the airway, they can't stand from a seated position, or they have immediate risk of environmental exposures or trauma due to unsafe locations, those individuals should be transported to the emergency room. Any signs of acute illness or injuries, abnormal vital signs, physical complaints, seizures, signs of trauma, or signs of head injuries should be transported to the emergency room. Otherwise, contacting med control is appropriate in releasing these individuals to another party. If it is family members, of course, they should be released to a sober family member. Patients, of course, can go to the police department for continued therapies and evaluation. An allergic reaction anaphylaxis, of course, this is broken up into 3 separate areas, where the first being just a skin eruptions. As long as they're not having airway compromise, just reassess those patients and then potentially transporting. If the patient starts having worsening symptoms, the use of the Epipen autoinjector is appropriate for EMRs and above. Any signs of respiratory distress, both either shock, you can start off with albuterol 2.5 to 5 milligrams. Just remember though, even though albuterol is in the green categories for EMTs, it is still a med control order per the scope of practice of the state of Ohio. So any individuals that, if they are not using the patient's albuterol medication, we have to contact med control. Otherwise, epinephrine is appropriate, and then treating the patient depending on the different other guidelines. In the altered mental status or coma, after obtaining blood sugars, it's pretty much into 3, again, different categories. The blood glucose less than 60, if we can orally treat those patients, and if they return back to baseline and they meet the proper criteria, they can be released at the scene. Otherwise, patients with a glucose of 60 to 250, think about other potential causes, even in the aspect of obtaining a cardiac monitor if necessary. If the patient has clinical signs of overdose from a narcotic, where they have pinpoint pupils with respiratory depression, then intranasal Narcan is appropriate to give. The philosophy with intranasal Narcan is always low and slow, giving 0.5 milligram aliquots intranasally every 1 or 2 minutes to a total of 4 milligrams is the appropriate way to treat these individuals. You do not want to slam 4 milligrams at one time because if so, they are bound to wake up very angry and also potentially will start vomiting all over the place. And there's been even some aspects with patients that woke up from a heroin overdose. It had other complications, including flash pulmonary edema or even a non-ST myocardial infarctions. Anyone over 250, of course, should be contacting ALS and then thinking of other potential causes. There is a non-transport for the hypoglycemic patient. Of course, the criteria is they have to have over the mental capacity, their blood sugar over 100 with normal vital signs. Those individuals can be released per med control order. Guideline 5 with back pain. Looking from the aspect of if it's a traumatic, think about spinal immobilization and then treatment of shock if necessary. If the patient is having upper back pain, one of the things that we have been seeing a lot of are thoracic dissections. So obtain bilateral arm pressures, and if there's a 20 millimeter difference, then of course ALS backup and rapid transport for these patients. Otherwise, if there's a low blood pressure or they have orthostatic pressures, think about rescue guard and then transporting those patients accordingly. The behavioral excited delirium, this has actually been broken up into two different sections, both in Guideline 6 and then in the future when we talk about the psychiatric side of it. The behavioral or excited delirium side is for those patients that are very agitated, aggressive, and all that stuff. Think about the different algorithms or guidelines potentially out there, including head traumas and overdoses. Try to get the patient from a stress environment, talking them down, and then if necessary, doing a rapid takedown with at least a minimum of 4 crew members. Basically, everyone should be taking an arm and then securing this patient. All patients should be secured in a non-prone, non-hog-tied type position, just for the simple aspect that we're trying to prevent the positional asphyxia. Cool them down if necessary, and then of course cardiac monitor and then transport. Dental pain, if it is a simple jaw pain suspicious for cardiac, getting a 12 lead. If there's trauma, of course, going to the appropriate guidelines. Bleeding should be controlled with direct pressure. Otherwise, if the tooth is broken off or has been ripped out, there's many different places that we can place the tooth in, including milk or your commercial products. We also, from the aspect, have the ability of putting the tooth back into place, which is simply don't scrub the roots, kind of sort of line it up where it goes into the mouth, as long as the patient is alert, oriented, understanding what is going on. Any alterations in mental status, we should not be putting a tooth back into the jaw for the potential risk of aspiration. Guideline 8 deals with the dialysis and renal failure. These patients, of course, if they're having shunt problems or bleeding fistulas, controlling the bleeding, and then if we do control that, you can, of course, release them or transport appropriately. Otherwise, if the patient is having any signs of pulmonary edema or CHF, we should follow those guidelines. Cardiac arrest, of course, consider PEA, hyperkalemia. If the patient is not having any problems, transport appropriately, check blood sugar if necessary, if it's low or high, treat per the guidelines. If dialysis within the past 4 hours and blood pressure is low, consider the rescue guard and again transporting. Guideline 9, epistaxis. kind of sort of tilting the head forward, placing an ice pack on there, pinching the nose, and then treating the patient for any hypotension or tachycardia as long as the bleeding is controlled. If the patient has a high blood pressure and they're still having nosebleeds, it's almost impossible to get those patients to stop bleeding without getting their blood pressure down. So of course, consider ALS support for that. The foreign body for an adult, this of course is broken down into are they conscious or not. If they are conscious, of course, the old Heimlich maneuver, which we are no longer able to say, it is actually now a abdominal thrust. And then from there, if they're unconscious or they become unresponsive while performing the abdominal thrust, start chest compressions and, of course, finger sweeps to try to clear the foreign obstruction. If we lose pulse, continue chest compressions, and of course, having ALS backup. In the hypertensive emergency, unfortunately, there's not much to do with this. I'm taking blood pressures, EKG, and then transporting appropriately. In the hypotension side, if the patient is symptomatic, then of course we're going to treat them. If they're not symptomatic, i.e. they're not complaining of chest pain, shortness of breath, or anything like that, then we can just continue to monitoring those patients. And then of course we have to figure out what is the cause of their hypertension. Is it trauma? Is it non-cardiac, non-traumatic, versus the cardiac? In the trauma or the non-trauma, non-cardiac, rescue guard is appropriate. But if it is considered a cardiogenic shock, of course we should be treating them per that guideline where the rescue guard is actually contraindicated. The flu side, very similar to the aspect of infectious control. We want to really worry about our PPEs, wearing your N95 mask along with goggles and gloves. If the patient's having respiratory problems, of course, consider airway management. Otherwise, look at pulse ox if they're dehydrated with hypotension, using the rescue guard. If the patient is wheezing, ideally use a HEPA filter on the end of the albuterol circuit with albuterol, and then of course consider CPAP. And again, just to reiterate, albuterol, if it is from our own stock, we must get online medical control to be able to approval for the therapy. Otherwise, if it's from the patient's stock, giving the patient's own medication is appropriate. And then ultimately transporting. In Guideline 14, dealing with the different poisoning overdoses or ingestions, think from the aspect if they're altered, or is there glucose problems, and then of course the Narcan, as long as they are having respiratory depression with this, pinpoint pupils, and then the suspected narcotic overdose. CO poisoning, using oxygen with CPAP, organophosphates. It is appropriate to give Duodotes. Most agencies, unfortunately, are not carrying Duodotes, but there are different caches throughout the state that do have the potential of getting for potential large exposures of organophosphates. Otherwise, going to the appropriate guidelines and then transporting. Under Guideline 15, again, this was similar to the behavioral excited deliriums, where the patient, universal patient care, removing the stress environment. If they're agitated or aggressive, of course, go to the behavioral excited delirium. If they're having anxiety attacks, consider ALS. If the patient is depressed, suicidal, or homicidal, we do have the ability of doing a mental health or what's called a pink slip hold. If the patient does have some problems, if you need to take them down, of course, similar to the behavioral, have at least 4 people. Do not sandwich, do not hog tie, do not keep the patient face down. They should be up at all times. The next piece here is the mental health hold, which is just the discussions and all that stuff. Under the respiratory distress, very similar to the influenza from the aspect of they having respiratory insufficiency, checking pulse ox, airway management as necessary. If they're having any signs of CHF, of course, going down to that guideline. If they're wheezing, giving the albuterol, as long as it's either from their own medication or we have online medical control. With, again, using the CPAP and then ultimately transporting these patients. If the patient does feel better, then of course they can be released at the scene. Under Guideline 17 with the seizures, looking at the universal patient care, spinal immobilization, and then the obtaining the cardiacs, and then looking to see if these patients are in status or if they're postictal. If they're in status epilepticus, contacting a ALS backup and then transporting appropriately. If they're postictal, of course, getting a focus history and then blood sugar and then transporting. In 18, the stroke, either suspected or known. Any patient with weakness or numbness, consider spinal mobilization. Otherwise, obtaining airway management, doing a stroke scale or the FAST, which is the face, arm, speech, time, and transport. Otherwise, limit on-scene time if the patient has symptoms less than 3 hours to 10 minutes, as previously described. These patients, we should have their head of the elevated to 30 degrees, make NPO, and then maintaining blood pressure, which would include using either a rescue guard to bring it up or other things in the hypertension guidelines, which would be transporting and getting ALS. Checking blood sugar, and then if they're able to swallow, of course, low, giving that, EKG, and then transporting. In the suspected abuse, consider spinal mobilization, airway management, and then knowing if it's either a physical or sexual abuse, making them NPO, assess for psychological problems on the physical, any physical abuse signs or symptoms, and then, of course, documenting. On the sexual abuse, discouraged from the patient going to the bathroom, and then, of course, discouraged about the patient changing clothes or washing prior to being examined. With anything in the suspected abuse, like everything else, make sure that you carefully document. These individuals, you have a high potential of having to go to court to testify. Under the syncope, patients with weakness or numbness, of course, should follow the stroke guidelines. Otherwise, if they just passed out, spinal mobilization initially, and then vital signs, checking blood sugar, EKG, and then transporting appropriately. The vomiting and diarrhea guideline, so similar to the abdominal pain, the aspect of orthostatic vital signs, making sure that obtaining blood guidelines. If they're having signs of hypertension, of course, using the rescue guard and then transporting those patients appropriately. The last guideline is the well person check. So this is really the aspect of starting for a community style medication treatment. Just remember right now the Ohio law prevents EMS providers from doing or performing community type things like well person checks. If they do have a well person, of course, any signs of trauma medical that needs to be appropriately treated or transported, of course, go that route. Obtain vital signs. If they have anything abnormal, of course, should transport for further evaluation. If the person does refuse transport, they can of course sign AMAs. If nothing is wrong with the individual, then of course just reconfirm and then have them call 911 as needed. In the obstetrical and gynecologic guidelines, with the obstetrical gynecologic guidelines under tab 4, the first one under guideline is OB patient transport. With this, most of the time OB patients will be a load and go type situation, especially if they are in the active labor stage. Most of these patients should of course be transported in a left lateral decubitus position with the potential of needing delivery at some point in time. Under guideline 2 with the vaginal bleeding, postpartum hemorrhage, if the patient is symptomatic, of course, consider using the rescue guard. And then if they delivered within the past 24 to 48 hours, think about performing a uterine massage, basically just rubbing the top of the uterus below the umbilicus to make sure that it's firm and well contracted down. Otherwise, then contact medical in transporting these patients. As previously stated, internal or bimanual vaginal exams in the field is not indicated. There is one time, though, that the potential that you might need to put your hand into the vagina, which we will discuss in a little bit. With the obstetrical emergencies, the first question to ask is the person having vaginal bleeding or abdominal pain. If they are, then you need to know if they are pregnant or if they missed a period. If no, then of course go to abdominal pain guidelines. Otherwise, think about obtaining orthostatic pressures, and then if they're complaining of labor, going to the next guideline, which will be the field delivery. Otherwise, we'll be transporting. If they're not complaining of abdominal pain or vaginal bleeding, but they're a known pregnancy, placing this patient in left lateral decubitus position, and then thinking about either seizure-like activities, which would be your preeclampsia, or the pregnancy-induced hypertension, which is actually the preeclampsia. The seizure activity is the eclampsia. Checking blood sugar, and then of course give them that if it's low, and then transporting appropriately. In the placental abruption, one of the other complications, this will be a painful vaginal bleeding, which of course there's not much that we can do in the pre-hospital arena except for fluids. So having someone that's definitely with a lot of blood, usually this is after a car accident, where if they're having a lot of bleeding, contacting a ALS provider. The rest of the stuff is for just the preterm, and then the rupture of membranes, of course, is just transporting. In the field of delivery, of course, ideally placing this patient left lateral. If they're having any abnormal bleeding or hypertension, going back to the obstetrical guidelines. If they're hypotensive, going to the hypotensive guidelines, which is traditionally just used in the rescue guard. Otherwise, inspecting the perineum to see if the patient is crowning. Not crowning, of course, just transport as rapidly as possible. If they're crowning in greater than 36 weeks, potential with the fetal delivery procedures, which will be on the next in the next guidelines. And then from there, if the patient is delivered with no complications, going to the neonatal resuscitation guidelines. Now, if there are potential complications, with the most common ones being either a prolapsed cord or a shoulder dystocia. Basically, the shoulder itself gets locked into the pubic region. Then we'll go down to the fetal delivery complications. Otherwise, if they're crowning in under 36 weeks, it's a matter of rapidly transporting these patients to the emergency room. In the field delivery procedures, haven't here listed the normal vaginal delivery or a breech presentation. Otherwise, under Guideline 6 with the field delivery complications, Again, putting these patients in left lateral decubitus. If they're not having any complications and it's a matter of the patient delivers properly, just go into the post-delivery type situation. Otherwise, on the breech presentation, as the previous guideline, in the prolapsed cord, the biggest thing is to discourage the mother from pushing, putting them into a Trendelenburg type situation, and then placing a gloved hand into the mother's vagina and lifting whatever body part is on the cord that has come out, wrapping the cord with a moist saline towel and trying to keep it warm. Of course, do not push the cord back into the vaginal region. The other thing that you can do too is have the mother get on all fours, and again, using your hand trying to push the part, usually the head, off the cord. The last one, of course, on the complication would be a shoulder dystocia, where it's, again, usually it's the baby's shoulder is locked into the pubic symphysis, and it cannot, basically they can't come out. This traditionally looks like a turtle type thing where the head keeps popping in and out. Ideally, just a matter of suctioning the oral passageways. If the head's not completely out, sometimes you have to push it back in, but that's usually done in the emergency room. Otherwise, it's just a little bit of transporting the patient. Under the neonatal resuscitation, this is traditionally similar to a cardiac arrest, where the first several minutes of a neonatal resuscitation is performed by a BLS type maneuvers. Of course, the biggest one is with the meconium, if they do have meconium, performing the nasopharyngeal suctioning, and if there is a lot of meconium, of course, having a paramedic available that can do deep suctioning is a benefit. Otherwise, if there's no meconium, it's really warm, sim, dry. Of course, suctioning the nose and the mouth out prior to that for the first 30 seconds. If the child's not picking up, evaluating respirations and heart rate. If they're breathing, but if they have problems with breathing, then of course, but they're blue, giving them some oxygen. If they're not breathing, the heart rate less than 100, going to positive pressure ventilations. And then if they're still not, after 30 seconds with airway management and the heart rate's under 60, start chest compressions. And usually the best way to check for a newborn is actually at the umbilicus versus trying to do a brachial, radial, or carotid heart rate checks. If their heart rate is greater than 60, of course, just monitor and continue with the positive pressure ventilation until they either pink up, or if they have the heart rate that drops less than 60, then of course start chest compressions. And then of course transporting these patients. From the aspect of pulse ox, most children, if you look at neonatal resuscitation guidelines, could take up to 10 minutes before they have a pulse ox in the 85 to 90 range. Usually in the first several minutes, their pulse ox is in the 60s, and then over time they do increase. Under tab 5, the pediatric, most of the stuff is similar to the adult medical resuscitations. So through this guideline, we'll be predominantly speeding through the majority of it, just knowing that most of it is all based upon pediatric weight, along with some little changes. In here, under the pediatric tables, just kind of sort of gives you an idea of what the typical pulse, respirations, and blood pressures are. Knowing, though, the general trends is more important versus trying to memorize specific numbers. As a newborn, we have a fast heart rate, and over time we slow down. With respirations, we have fast respirations, and then, of course, over time we slow down. The blood pressure, of course, is the opposite. I mean, we have a low blood pressure, and then over time our blood pressure increases. There's a rule that I kind of sort of teach the paramedics and others. It's my 1-5-10 rule for estimation of pediatric age and weights. So often we get on scene and we never know what the child's weight is. So if you can remember, 1-5-10 is 10, 20, 30. Of course, these are ideal, these are the ideal estimated body weights. And there's a lot of kids that are actually larger than this rule. So 1-year-old is approximately 10, a 5-year-old is approximately 20, and a 9 or 10-year-old is approximately 30 kilograms. And then abdominal pain, very little different from the adult, the allergic reaction, anaphylaxis. The only huge difference on this is the weight for the albuterol. If they're under 10 kilograms, giving a dose of 1.25 milligrams, versus the other kids, 2.5 milligrams nebulized. Now remember, in the adult, it's 2.5 to 5. So if you have a 12-year-old that looks like an adult, then of course kind of sort of treat that child that way. And always remember, albuterol is still a med control order, even if or unless they have their own medication. After that, if they're still having respiratory distress, usage of the Epipen Jr. And remember, from this aspect, the Epipen Jr., there's a size and weight. So as long as the child is over the age of 8 or over 55 pounds, use a traditional EpiPen. Otherwise, if they're under 8 or under 55, use the Epipen Jr. And again, this is an ideal body weight versus what the patient's actual weight is. Altermental, very little differences. The only aspect, of course, is the glucose, given 0.5 grams per kilogram. And of course, if they max out at 15 to 30 grams, anything in the adult, do not go over an adult dose. The Narcan, of course, is 0.1 milligram per kilogram, and again, similar to the glucose and all the rest. And, if they max out at 0.5, then of course don't supersede that. On an ALTI or an apparent life threat event, this is a situation where a mother calls because the child had a frightening event. Usually the child becomes limp, they become blue, they stop breathing, or they have some choking or gagging with this, or even the aspect of a seizure. By the time that we get there, the child is usually back to normal. From this aspect, we simply check vital signs and then transport these patients. Foreign bodies, very little different from the adult, just from the aspect of the abdominal thrust and the chest compressions. And then the infant foreign bodies, of course, the back blows and chest compressions that were taught in the BLS maneuvers. The hypotension, very little difference. Just remember from the aspect that the rescue guard does have a weight restriction, which is usually 25 pounds or approximately 10 kilograms. The size or the weight is not the issue. It's usually the size of the mask. So sometimes some of the CPAP pediatric masks can actually work in conjunction with the rescue guard. Otherwise, it's just transporting. Operation Safe Haven or infant abandonment, Ohio law basically has a spot where mothers, within 30 days of delivering a child, for any concern, can drop the child off to a fire, police, even to social workers and all that, where the state takes custody of the child. With this, of course, trying to do anything to protect the child, notifying dispatch, and then your child and family's job services. Don't try to coerce or pursue the caregiver. If you can get information on a child, such as birth dates, medical problems, or anything like that, then of course that will be beneficial. Poisonings and overdoses is very little different. Of course, it's just the size. Same with the psychiatric patient. The respiratory distress. The seizures are the same way. The suspected abuse or neglect is the same. Vomiting and diarrhea is the same. And then into the environmental emergencies. With this one, the first, of course, is the bite and ventilation. Does the patient actually need to be transported to the hospital, if not just contacting med control and going from there? Otherwise, immobilizing the patient and then cover. If the person is having any allergic reaction, of course, follow those appropriate guidelines. In the burn, this is kind of sort of broken up into 3 different parts. Of course, airway management deal with first. If they have burns to a area that have to have rings removed or bracelets because of potential constrictions, of course, do that. And then if it's a thermochemical or electrical. Under the thermal, this is one of the parts where you should always apply high flow oxygen. Under 20%, of course, just putting the area with cool, normal saline. Traditionally, do not saturate or keep applying a lot of water just because we don't want to cool these patients down. And then placing dry, sterile dressings, especially if this is going to be a prolonged transport time and there's at risk of a saline gauze drying out, which of course would potentially cause problems when trying to take a dried out saline gauze off the skin that would tear the skin. Under the chemical side, of course, get the exposed area. Most of the time, just getting them out of the contaminated clothing will do a lot for decontamination. And then flushing the area with water, specifically or especially if it's the eye is involved and all that stuff. There are, though, certain chemicals that do not like water. So, of course, always look at the different apps and all that stuff for any of the hazmat issues. Under the electrical burns, of course, think about spinal immobilization, and then if the patient does not have a pulse, going down the cardiac arrest guidelines. Knowing that most patients will be able to get back with chest compressions and defibrillation. Otherwise, if they have problems breathing or they're not breathing after you get the pulse back, continuing the rescue breaths, 12 lead EKGs, and then transporting appropriately. Do have in here the rules of 9 for burns. And then a drowning and near drownings. Again, there's 3 breakdown categories. After spinal immobilization, if necessary, checking for mental status. If the patient is awake, alert, and again they have mental capacity, just getting them out of the wet and or cold clothing, monitoring vital signs, and then encouraging these individuals to be transported to the hospital. If they don't want to, let them know that some victims potentially have problems at 4 to 6 hours after the incident, and it's always the potential sometimes of going by or having someone monitor that person. In the wake but altered, of course, getting them out of the cold, wet clothing, suctioning as needed, checking blood sugars, utilizing the altered mental status guideline, monitor vital signs. If they're having difficulty with breathing, of course, looking at the CPAP, and then transporting. If they're unresponsive, the first question to ask is, do they have a pulse or not? If they do not have a pulse, of course, follow the cardiac guidelines. Otherwise, it's similar to the wake but altered level consciousness. In the hypothermia, three separate areas again with either the heat cramps, heat exhaustion, or heat stroke. Otherwise, it's really checking the blood sugar. If they're having any active seizures, of course, going to the seizure guidelines. On the left-hand side, there are some different things, the potential of causes for hypothermia, including medications, cocaines, some of the plants out there, Jimson weeds and stuff like that, and then of course infections. The biggest, of course, is looking at cooling these patients, so packing the axilla, the growing around the neck. But there's also some literature now that's showing putting ice on the palms, the soles of the feet, and then on the cheeks actually have some benefit. In the hypothermia frostbite, of course, is a systemic hypothermia versus a localized cold injury. If it's a systemic hypothermia, of course, if the patient does not have a pulse, going down to the hypothermia cardiac arrest guidelines. Otherwise, getting them out of their wet, cold clothes, and then warming them up. Be gentle at the best. Low blood pressure, of course, usage of the rescue guard. And then following any other appropriate guidelines. In the localized cold injuries, this is pretty much just getting them out of the wet, cold clothing, and then warming those individuals. Tab 7 trauma guidelines, the majority of trauma scenarios, we are very good as EMS providers. So the majority of this, again, will be similar to Tab 5, where just hit the highlights and all that stuff. Under Guideline 1, the general trauma criteria, this is has the Ohio revised area, specifically for what was the original RPAB Region 4, which was the trauma criteria Region 4. Now that it's been merged to Trauma 1, there's might be some little bit of differences in the future. Otherwise, the blue for the adults, the red for the pediatrics, and the green for the geriatrics, either for your major your trauma major versus your trauma intermediates. Guideline 2 has the combination of the pediatric and the adult start triage, or the jump start triage, which can the patient walk, breathe, assessing respiratory rates, perfusions, and then mental status. Traditionally, in most trauma scenarios, they should be load and go type things, so under 10 minutes. Of course, there are some potential delay in aspect if we have to secure the area or getting the patient out of the vehicle. Otherwise, transporting and if necessary, consider air medical transport if it's under that 30-hour. On the bleeding or hemorrhage control, of course, the ideal is direct pressure, bleeding control with pressure bandage. Hemostatic dressings are available out there, both some of agents along with some of the different type dressing materials that we have now. If the wound is amenable to a tourniquet, of course, using a tourniquet. Otherwise, contacting med control and transporting. Abdominal trauma, like the majority of them, just spinal immobilization, airway management, rapid transport for penetrating, stabilizing any fractures or bleeding and all that stuff. Chest trauma, this is the very similar. Under the crush injury or the compartment syndrome management, so any patient that has been potentially crushed or will be for at least 4 hours, this is potentially things like a house collapse, or the patient got stuck into a grain silo, where they can actually develop something that's called rhabdomyolysis, which is a breakdown of the muscle. With rhabdo, one of the potential things that gets spilled into the bloodstream is potassium, or they can develop what's called hyperkalemia, or an elevated potassium level. So with this, one of the medications that could help combat is high dose albuterol, 10 to 20 milligrams. Now again, remember that this is a medication that still needs medical control clearance to give. Under the eye injuries, just a matter if it's blunt versus penetrating versus a foreign body. If it's blunt, of course, patching both eyes, penetrating, stabilizing the object along with covering the unaffected eye. And then any chemical or foreign body exposure, just doing continuous saline flushes until they're able to transport. Sometimes if you can't irrigate using bottles, attaching a nasal cannula to a liter of fluid and then putting the prongs over the bridge of the nose allows for a easy, simple irrigation style. Head traumas, the biggest thing with head traumas, of course, are the two major killers, which is hypotension or hypoxia. So maintain using a ambu bag if necessary with good ventilations, contacting ALS if necessary, any of your basic airway maneuvers, and then transporting appropriately. If they start having seizure activities, of course, following the seizure guidelines. Multi-system trauma is similar to adding everything together. GCS, having gag reflex, if not basic airway maneuvers or airway management with oral airways and BVMs, and then rapid transporting. Musculoskeletal traumas or amputated body parts. The biggest is, of course, are they having a spinal immobilization and then stabilizing any fractures. Femur fractures, of course, using traction devices. Pelvic fractures, either using a sheet or one of the commercial grade pelvic binder devices, which actually has been proven more beneficial than trying to apply a sheet for splinting. Otherwise, any pulseless extremity, potentially repositioning the extremity to regain the pulse. With a amputated body part, if it is amenable, putting this part, wrapping it with saline, putting it on ice, and then transporting. Otherwise, do not immerse any body part into a saline bottle. That just causes the body part to expand, which will make it futile in the future for reimplantation if possible. Obstetrical trauma, the biggest thing here is taking care of the mother. You have to resuscitate the mother in order for the mother to take care of the fetus. There is on the left hand side, the abdominal size depending on weeks. Knowing that 20 weeks, of course, is the one spot where the fetus is at the level of the umbilicus, and that's where the potential in the future of causing IVC syndrome or pushing down on the inferior vena cava, hence the reason why we should always put these patients in left lateral decubitus position. Pediatric trauma is very similar to everything else. Spinal trauma very similar to the head traumas. In the police custody with the pepper sprays and conducting injuries, of course, maintain spinal immobilization, airway management if the patient's combative, following the behavioral guidelines. Any other evidence of medical or trauma should follow those guidelines. If it's a simple pepper spray or conducted energy, the pepper spray, of course, remove the contaminated clothing and irrigate. There has been some discussions with either use of milk or the Johnson & Johnson Tearless Baby Shampoo helps with getting the pepper spray off. Otherwise, if they're complaining of any shortness of breath or wheezing, following the respiratory guidelines. If they have a history of asthma or COPD, then observing those patients for at least 20 minutes. Knowing that usually by the time that you decontaminate those patients, the 20 minutes would go by. Otherwise, on the conducted energy side, if they've been tased or some other device like that, any history of cardiac or complaint of chest pains, of course, getting a monitor, and then transporting those patients. If they're not having any problems, wound care, hemorrhage control, and for EMTs and above, can remove the barb. It's quite easy to do. Just place a gloved hand on the patient, and then with a pair of pliers, pulling the barb in a straight off perpendicular to the skin. Just remember, prior to removal of the barb, one of the first things that you do want to do is make sure that you disassemble the module from the gun itself. Otherwise, after that, give the barbers back to the police officers so that they can have. There is a release at the scene for this. So after 15 minutes, if no problems, they have a GCS of 15, they have normal vital signs, they're not having any muscle contractions, no history of cardiac problems, there's no dart in the eye, face, neck, breast, axilla, groin, or spine. Of course, those things should always be transported to the hospital for a physician to remove. And then just remember to remind the people that if they have not had a tetanus shot within 72 hours, they should have a tetanus shot. The hazmat, just simple hazmat training, and then the nerve agents and weapons of mass destructions. Of course, remembering that utilizing a Dewey Dodes or the Mark I kits as necessary. Under Tab 8, Medical Procedures, Guidelines, and Equipment, the first one will be the major one that I'll be talking about, which is notifications of special procedures. From this aspect, anytime that you do a King Airway, LMA, or endotracheal intubations, not so much EMTs with endotracheal intubations, but anything where a blind insertion airway device is performed, or chest compressions with a CPR device, usage of AEDs, or from the aspect if there's a concern about patient care at a hospital, there should be notification. If you email, always put in the subject heading confidential peer review information protected by Ohio law 4765.12. This, of course, sets up the status of peer review, which protects those email types. If unsure what to do or how to give, the next section is just the QA/QI notification form. This is ideally what we're looking for, different procedures and all that stuff. Under the pulse oximeter, these are different procedures that can be formed, nebulized treatments, continuous CPAP, with the different either a FlowSafe 2 or a pulmodine therapies, using intubations, different sizes, and then the next is, of course, the LMAs. Capnography. On the Northwest Ohio EMS Consortium website, there are some links to some YouTube videos that helps explaining more about capnography. This is, of course, the gold standard for any patient that has an advanced airway in. So if you put a King airway in, a laryngeal mask, surgical cracks, endotracheals, these type patients should, of course, have capnography placed. Tracheostomy tube care, suctioning, and all that stuff. Rescue guard and rescue pod. The scene rehab general, just going down the whole process for a patient that's been exposed and all that stuff, either heat stress versus cold stress, vital signs and all that stuff. The second one is the scene rehab for responders. We're kind of sort of looking at NFPA standards for being able to continue their treatments. Otherwise, following your fire department, if you're on a fire department, SOGs and SOPs. AEDs with EKG placements. Do have in here a picture for the different locations for the leads. Usage of either a Lucas 2 or a Zoll Autopulse. Blood glucose monitoring, administration of aspirins, the epinephrine auto-injectors, the mucosal atomizing devices, with the restraint guidelines. Avul's tooth that we talked about before, taking someone's helmet off, uses of pelvic binders, and then the selective spinal mobilization. And again, there is a video 1-hour presentation on the Northwest Ohio EMS Guidelines section of the site that explains why we are now doing selective spinal immobilization. Splinting, and then ultimately usage of the tourniquets. Tab 9, the medication. With this, this will be all the different medications that you can perform as a provider. Again, just knowing that albuterol, once again, if it's from the patient's own medication, you do not need med control. If it is from your stock, obtaining med control. Each of the different medications, though, it's how it's laid out. It'll have the action, the precautions, the contraindications, any of the potential side effects, and then at the bottom, the indications along with the dosages, both for the blue and for the adult, or red for the pediatrics. And then, of course, aspirin with atropine, your Duidotes with epinephrine, glucose oral, Mark 1 kits, naloxone, your nitroglycerin. Again, just remember that this is always a med control order no matter what. Oxygen administration, different dosages with that. Preladaxine, which is one of the parts of your Duidote or Mark 1 kits, and that's the end. If you have any questions, of course, please do not hesitate to contact any of the medical directors. Have discussions with your chief about this. All providers should fill out in the Northwest Ohio EMS guidelines. There is a form that deals with guideline acknowledgement. This form, of course, looks similar to this, where it has the information along with providers and all that stuff. The Northwest Ohio EMS, of course, can be www.nwoems.com. If you have any further questions, of course, just ask.